Good afternoon and welcome to NQICAN's first Lunch and Learn as part of Clinical Audit Awareness Week 24. So my name's Vicky Patel, I'm the Chair of NQICAN and Clinical Effectiveness Manager at the Rotherham NHS Foundation Trust, joined today by Marina Otley, our NQICAN General Secretary. You'll note the event's being recorded. We'd love to see your cameras on though. We ask if you can please remain muted to allow less noise for our speakers and the recording. Chat function is live and we'd love to hear from you, so please do get posting. We're just going to move on to the next slide then, and you can see the whole programme of Lunch and Learns for the week. Head on over to the HQIP's website, free to access links available for each day, and you can see the key themes that we're holding. Today's is on patient safety, effectively utilising clinical audit to prevent avoidable harm, and we're joined by Rachel Poole, who works with the patient safety implementation team at NHS England. So before I move on to look a little bit more closely at today's agenda, I'm just going to hand over to Chris Gush, who is the CEO of HQIP, who'd just like to spend a few minutes with you, really setting the scene from the HQIP perspective. So I'll hand over to you then, Chris. Next slide, please, Marina.
28th of June, and it's particularly significant as it marks our NQICAN to highlight the critical role of clinical audit and quality improvement in the healthcare system. So as Vicky said, I'm the Chief Executive of HQIP, and I'm really pleased that we can start to highlight how clinical audit is on a cornerstone of quality improvement in healthcare. It helps us to measure and ensure that we're delivering the best possible care through our patients. Through systematic evaluation and the implementation of necessary changes, clinical audits drive the continuous enhancement of healthcare services, and national clinical audits are cornerstones of that commitment, maintaining and enhancing the quality of healthcare. They provide that systematic approach to evaluating the care delivered against specific targets, standards and criteria, allowing for continuous improvement and greater patient safety. They establish benchmarks of best practice by comparing outcomes and processes across different settings and providers, and developing national standards and ensuring consistency and quality. The systematic collection of and analysis of data help identify variations in clinical practice and outcomes, informing targeted interventions and quality improvement initiatives. And they also enhance accountability by providing the public reporting of audit results, fostering a culture of transparency and allowing stakeholders, which includes patients, to make informed choices about their care. They guide resource allocations, ensuring that funding and efforts are directed towards areas with the greatest need for improvement, and help identify areas where cost-effective changes can lead to better outcomes. By highlighting this best practice in areas for improvement, national clinical audit drive enhancements in clinical care, leading to better patient outcomes, and they've been associated with reductions in mortality rates and complications in various clinical areas. Continuous monitoring through the audits provides an ongoing evaluation of patient safety initiatives and ensuring that safety improvements are sustained over time, and promote a culture of safety within healthcare organisations, encouraging staff to prioritise all aspects of care, fostering an environment where reporting and learning from errors are encouraged and supported. Audits often involve patient feedback, ensuring that the patient perspective is included in safety improvement efforts, and engaging patients in their care processes enhances safety satisfaction. So today we commence with a very special patient safety lunch and learn event, led by Rachel Poole, the Head of Patient Safety and Implementation at NHS England. Her expertise and insights will set the tone for a week filled with learning, sharing and celebrating achievements in clinical audit. And throughout the week, HQIP will be sharing invaluable resources related to various clinical categories online, and we encourage everyone to take advantage of these materials, which are designed to support your ongoing efforts. We're also delighted to celebrate the accomplishments of individuals and teams through our Clinical Audit Awards. And these awards will recognise outstanding contributions in several key areas, including patient safety, patient public involvement, healthcare inequalities, and sustainability. And the winners are going to be announced during a series of online events, and I urge you to stay tuned for further information. And also, can you take this opportunity to involve your wider organisations within the NHS in celebrating Clinical Audit Awareness Week? It's a time for us all to acknowledge and reflect on the critical work being done across the country to enhance patient care through rigorous and insightful audit. And lastly, I encourage you to utilise all the free resources available on the HQIP website. Download, share and implement these tools in your practice, and use the hashtag CAAW24 to share the activities on social media. And let's make this week a powerful demonstration of our collective commitment and quality improvement and patient safety. So thanks a lot. And I'd like to hand over now to Marina and Vicky.
Oh, lovely. Thanks, Chris. That's brilliant. It really starts to set the scene for the week and obviously for today as well. So I think in the interest of time, we'll move swiftly on to the next slide then, just to touch on today's agenda. Obviously, some of it you've just heard from Chris as well, in the fact that we've obviously got we're delighted we've got Rachel Paul that's joined us today to talk all things patient safety and really making us have that focus on how we can further drive preventing that avoidable harm and keeping our patients safe. Obviously, our Audit Hero winner is going to be announced, and we're actually going to hear them present as well. But throughout the whole of the next hour, we're really touching on the importance of clinical audit awareness to both the clinical audit and wider QI community as well, and making sure that we are actually working together to make things better. So once we've heard from Rachel and obviously our winner as well, there's the opportunity to ask questions. Chat function is enabled, as we've said, so please do keep posting and popping questions in there. We will try to cover everything within the time slot we've got for the Q&A, but obviously we will also collate any that we don't get round to responding to, so that we can actually publish that alongside the recording and the slide pack as well. Before we close at 1:30, we would like to do an interactive evaluation again, as we have done in previous years, on the screen, and Marina's going to walk us through that once we get there. But one of the key things to really say, and I think Chris has already touched on it really, is to take away a key challenge back to your own organisation from today's lunch and learn around how we can effectively utilise clinical audit to really keep our patients safe and prevent that avoidable harm. So if we can just move on to the next slide, we just really wanted to just do a really quick refresher for you on NQI CAN. It is that week to shine that light on clinical audit, as Chris has already said. Within our national network, we've got 10 regional networks. We're going to pop some links and contacts into the chat for you to get in contact if you're not yet a member. NQI CAN's got a common purpose, it's got a forward plan, and our regional networks are all actively involved in helping us deliver on that and taking that voice from their regional network members into NQI CAN and taking the voice back into the networks from bodies such as NHS England, HQIP, NICE, GIRFT, and many more. Next open quarterly meeting that we'll be holding is on the 24th of September at 10 AM, and we'd love to see you there. And the NQICAN website hosts the open links to those. So we do have a network and sharing forum where you can join and interact with colleagues around the country. And as of this week, we're really excited to announce that we've moved the forum across to the Future NHS platform. So it's a really exciting move for all of us in terms of making that networking far more easier. Most of us have now got a login to the Future space. Once you're logged in for the day, you can swiftly move between any workspace that you're a member of, and you can set your notifications to your inbox, which fits with how often you want to hear from us in terms of new discussions being posted, people that are responding to questions that are already on there. You can manage when you want to get those notifications sent in. If you were a previous member of the forum, you should receive an invite to join the NQICAN workspace if it's not hit your inbox yet already, and you continue to network. And if not, we'll pop the links into the chat so that you can request to join. Very briefly, just again want to push that National Clinical Audit Workspace on Futures for that knowledge and learning hub around taking action on National Clinical Audit findings. So that local networking on the NQICAN workspace and that National Clinical Audit networking on the knowledge and learning hub. And again, the links will go into the chat for you. So this week touches on the 5 key themes, and today's patient safety, but really getting you to think about how we can effectively utilise clinical audit to support each of those key themes. We'll touch on some key points, we'll hear from those key speakers and set you those challenges to take away. So if we just move to the next slide, it's just sharing with you again what we challenged you with last year around aligning your strategies, your policies up with the patient safety work stream, and especially the patient safety incident response framework, and actually was your clinical audit programme and improvement plans looking at those patient safety elements and preventing that avoidable harm. So we'd love to know how you've got on with that. So again, if you can post any any successes from the last year in your own organisations where you took those challenges forward, but also where perhaps things weren't as easy to accomplish, and maybe how you've managed to get over that, so that we're sharing that together today and networking. And then finally, if we just move on to the last slide before I hand over to Rachel, then it's just further thoughts for this year. Busy slide. It's meant to as a signposting for you to take away when the slide packs are posted, but it's really around, are we actually measuring when we've implemented that evidence-based care to ensure that we've introduced it both safely and with efficacy? What are your top 5 patient safety concerns in your organisation, and actually are you working collaboratively with your patient safety teams to measure those and make sure they go on your clinical audit programme? Do you attend your patient safety committee? And when you've got those clinical audit outcomes in your hands, do you then align them with what your patients and staff are feeding back to you in terms of what they're saying is important, and also aligning it with the concerns and risks in your organisation? And then when you're taking forward your improvement plans, are you doing so collaboratively with your patient safety and experienced teams? And then finally, that triangulation with wider information that you know for context, so you're really getting underneath the root cause of why your clinical audit outcomes are as they are, and then holding those sharing and learning events in your own organisation so that you are collaboratively working with your safety and experienced teams. So it's just to get your thoughts in the right place, really. And if we move to the next slide, we'll hand over to Rachel Paul, who is our key speaker for today and the Head of Patient Safety and Implementation at NHS England. So over to yourself, Rachel.
Hello everyone, I'm Rachel Paul, Head of Patient Safety Implementation at NHS England, and I'm delighted to join you today for Clinical Audit Awareness Week. It's great that you're running it online. I have a disability and it's really hard to get carers to take me to events, so really delighted that you're doing something virtually which improves accessibility to everyone. So I mainly look after the implementation of the Patient Safety Incident Response Framework. Can we move to the next slide, please? And the next one. So in preparing for this talk, I reflected on my time when I worked in audit, and the tagline I used in promotion material to get people involved was "Make your mark." And so I'm going to talk to you today about using clinical audit in PSAF, the Patient Safety Incident Response Framework, to make your mark in patient safety and prevent avoidable harm. Next slide, please. So going back to the beginning, why is there a PSAF and what's all the fuss about? So previously we had the Serious Incident Framework, and it aimed to facilitate learning by promoting a fair, open and just culture that abandons blame, not simply linking the actions of individual staff, but also the system. And that's something that we wouldn't disagree with today. But several national reports, so the House of Commons Public Administration Select Committee, the Parliamentary Health Service Ombudsman and CQC all found issues with actually embedding and sustaining improvement as a result of that investigative activity. And academic literature also found issues with the way that the safety work was being carried out. Next slide, please. So what we've ended up with in PSAF are the movement from prescription to principles. So under the Serious Incident Framework, it was defined the threshold at which incidents needed to be investigated. Under PSAF, we have principles. So these principles were developed, consulted on, and tested in 24 organisations. And they are compassionate, proportionate, systems-based, and supported. So the compassionate is giving patients and families and staff, crucially, all three of those affected by patient safety incidents, the opportunity to engage meaningfully. And by meaningfully, we mean the chance to actually have an influence on the investigation and tell their story and involve them in any learning response and improvement activity afterwards. Proportionate means that not all of the incidents require a learning response, and to focus responses on areas where there's greatest potential for learning and improvement. Systems-based means looking beyond the decisions and actions of individuals delivering the care and spreading your net wider to consider the influence that wider system factors have had and the interaction between these elements on the individual's behaviour or actions. And then supported. So we're moving from a command controls oversight function to a more facilitative and enabling approach. And ICBs and regions will take a lead more with helping organisations coordinate responses between multiple organisations, but also learning between organisations and across boundaries. Okay. Oh, I'm taking control and now it's whizzed through. Right, there we go. So what does PSURF involve? At a very high level, it involves these 3 steps. So planning, an incident response, and that all embedded in improvement. And what we're trying to do is not just implement a framework, but lead a culture change. And some have described that as a movement. So what would be some flags that we're achieving this culture change? So what's really important here is we don't want to just repackage this. That's that cartoon on the left-hand side. We're not repackaging your muesli as muesli. We need tangible change and we really need it to feel different. And some of those examples of where it can feel different are building connections, enabling conversations, changing narrative and having an open approach, and oversight functions being less transactional and leading to tangible and measurable change. So at the end of 2023, we did a bit of exploratory work. What were successes that people were seeing? We did then come on in 2024 to discuss opportunities and challenges, but we just wanted that space to appreciate and end the year well on what has been what we've been achieving. And so we had multiple responses and they sort of fell into 4 different themes. So learning and change, faith-based, collaboration and cross-system working, and investment and long-term approach. And this to the right is one of the examples. So people were finding a safe space to share and learn, escalate concerns, pinch with pride, develop whole system working and reducing silos, act as a critical friend, foster self-reflection, and provide insight and act as a professional support network. This is helping to encourage and model the learning healthcare system, patient safety culture, and quality improvement approach that PSURF is aiming to achieve. And we couldn't have really ended the year better with that quote. Some really great work going on there. I'm sure supported by right across the system, including the Health Innovation Network. Bit of a lag with this slide. So just reflecting on what we said those flags for cultural change could be, we have definitely made a start on all of them, acknowledging that the transition to PSURF is just the start and actually creating that change is going to require a longer term approach. So going more into the detail of PSURF now. So organisations took at least 12 months to do their planning, and that involves some diagnostic and discovery work, analysing their safety data, their capacity to respond, getting governance and quality monitoring in with systems and processes for oversight, and then creating and curating and agreeing their patient safety incident response plan and policy. And those will be available for organisations online. So have a look at your local organisations, plans and policies to understand what they mean to you locally. Just waiting for the slide to catch up with me. So all that planning, incident response and improving is done within the background of the patient safety incident response framework, the standards, the oversight specification, a whole bunch of supporting guidelines and some tools available in the PSER toolkit. And that's all underpinned by those 4 principles. So where does audit fit in with all of this? So in our puzzle of safety intelligence, which we use to inform our incident response plans, audit is one of those aspects. And you'll see other things like your learning from death, your friends and family data, and all of that sort of combines for you to understand what your safety profile is. And so now we've got, by using different data sources, we get another snapshot of what we're trying to understand about our local system or regional system, whatever level of the system you're looking at. And so let's look at an example of the relationship between clinical audit and PSER. So taking the National Diabetes Audit, essentially your organisation has triangulated the results of that with other data, and it's indicated that diabetes care should be an organisational priority. And so what we want to then do is we've got the signal, we need to look at something in a bit more detail. So we need to understand the work systems and risks involved in diabetic care more. So when we come to the patient safety incident response planning and we set that as one of our priorities, we would then consider, well, is it sort of any incident involved with diabetes, or are we looking at something a bit more specific? So incidents where patients are requiring hypoglycemic rescue, and so they should receive a learning response. And in Tracy Hellerhay, who's the patient safety incident response policy lead, and Mark Smith, our patient safety partner, did a review of the published patient safety incident response priorities, and those are in the word cloud there. If you look at them, you'll recognize some that link up to audit, and that can give us an indication of maybe what specific bit we need to hone in on, whilst remembering our PSER priorities of compassionate involvement and proportionate learning responses. So the patient safety partner also looked at the plans from a sort of patient perspective. He found that just over half of the plans mentioned the public had been involved in developing them, and about only 10% of them engaged with their local health watch. Only a third of plans did not base the learning response on the level of harm. So that's an area that we're going to be looking at improving in the next, when organisations come to review their plans. And then in a fifth of plans, so 20%, he felt that it would not be clear to patient or family member involved in an event what the learning response would be in their case. But 80%, he felt that it was clear. So just some points that we've taken away and discussed with our regional leads about how do we change this within the system, and so we'll be embarking on some work on that in the next few months. So another aspect that we're considering in PSER is how do we embed inequalities work within PSER. So as part of plans and the framework, organisations are starting to look at both the data and the systems and processes around that are collecting the data to have it available to analyse what inequalities there are. And I think this is really one area that audit could help inform us, particularly the sort of national audits, where some of that data is collected more automatically and does contain some more of those protected characteristic data points. And so I think that's a really positive area that that audit could help inform PSAF plans on. So Tracy and Mark reflected back on reviewing the plans, and that yes, this is really just the beginning of the safety journey. A lot of organisations are understandably relieved to have actually transitioned. They've now got an informed way to make decisions rather than just reacting or tick boxing. This has met the harm thresholds we must investigate, and able to prioritise resource into actually making improvement as well as doing the learning responses to inform that improvement. And the plans are a really rich source of data. We've got lots of different people interested in analysing them. And so rich source of data about safety concerns across trusts in England. And the review highlighted the chance to improve clarity for patients, focus even more on inequalities, and focus on improvement priorities rather than response priorities. So moving to the next bit of PSAF, you've had an incident and you've identified that you're going to do a learning response. And this is where our systems-based component comes in. So in systems-based approach, it's different. We use incidents as a window on the system. We might not see the whole system, but we can understand parts of it better. And so this person will likely have multiple encounters with healthcare throughout their life, and that's indicated by the crosses on the arrow. Within each encounter, a series of processes will occur to meet healthcare delivery goals, for example, diagnosing and managing a specific condition. And there can be organisational goals, such as aiming to do it within X number of weeks to get a performance payment, a professional aiming to do a new management safely. So in the past, when something went wrong, a linear model like root cause analysis might be used. And essentially, this involves looking at the sequence of events and aiming to remove the human error or performance issue, illustrated here as dominoes. And so by removing the human error domino, it stops all the dominoes falling down. The problem with the linear approach is that we are expecting the human to be the linchpin, and that can sound like they need to take more care to select the correct medication. They need to just input it correctly. But underneath those sentences, there's an iceberg of everything a clinician is having to do. So providing great care, recording everything down on the IT system that has just been changed. They can't quite remember how to do the thing they need to do. Reviewing OBS, that's on a different platform, checking imaging on another. Oops, they've now passed the time, so they need to put in their password again. They've now got to check that it's the correct patient on each system. They're simultaneously being bleeped, and someone's also requesting them to sign a prescription, and the patient's asking a question. And so in the context of that, all of that activity in that system, how do we help the human do the right thing? And so what we need to do is flip that linear approach all on its head. People are the set component in the system. They've got a fixed range of human capabilities and functioning. And yes, we are pretty good actually at adapting and providing flex in the system, but we need to reserve that capability for when it's really needed. And that should not be just during normal routine work. So it's about taking into account humans' limitations and designing the components of the system according to the people rather than making people adapt to make that system work. And so to make effective changes, we need to understand how a process and system is designed to optimize the fixed range of human capabilities and functioning. So along the processes, There will be work systems, so that's indicated by those hexagons with crosses in, and that's a combination of elements that interact. So that's taking a more systems-based approach to consider the interaction of elements such as the tasks, the tools, technologies, physical environment, organizational conditions, external environment, and how they all interact to produce the outcomes. And what we want to do here is enhance the positive interactions and mitigate the risk of others and prevent that avoidable harm. And that can also look like good catches. So when something happens to avoid harm, how do we enhance that more and spread that learning and that really positive interaction? We can also take other types of system-based approaches. For example, here an outcome is patient harm. We understand the events, processes and conditions that led up to the harm occurring, but then delve down through layers of the system to understand what contribution the rest of the system made towards this occurring. And so the blame doesn't then land on the person when, let's say, the music stopped. It recognizes the impact of decisions made in the blunt end and how that has impacted on the sharp end. Another factor we need to consider is how much of the system do we actually understand? And there are different lenses to look at this. So how is work actually done? How are the people on the ground actually doing it and to achieve their goals? How do they actually make care happen? Then we have workers disclose. So what do they tell people that they do? And that can be affected by, how they perceive what they say might go down. And then workers imagine that can be things like, how do your senior managers think that the work gets done? And then workers describe, that can be what is written down in policies, procedures, guidelines. And there can be gaps between these different types of work. And what's really actually important is to know how work is actually done and what those gaps are. So, for example, if you're saying they just need to follow the guidance, why is that guidance not being met? Maybe there are actual reasons that are there that actually enhance safety as to why that guideline, it just doesn't work in the environment it's in. So I've covered incidents as a window on the system, recognizing the interactions and emphasis on exploring everyday work. And so that's providing another aspect on another view on the system. So I'm just going to go forward. So to make improvements, we need to make them in a systems-based approach as well. So that's moving your actions from least effective to most effective, and taking into account those that make persons-based versus systems-based. There's a great safety action development guide in the PSF toolkit that can help you achieve that. So audit can inform the safety profile of an organization and patient safety incident response planning. The patient safety incident response methods can be used to better understand maybe areas that audit has highlighted. And the patient safety incident response toolkit can focus on effective improvement rather than response. And audit can be used throughout the patient safety incident response to identify the areas that are potentially needing more analysis, to look at maybe pinpointing this bit of the process that is the specific bit that has got an issue, and then also in improving, it can help measure those improvements. So thank you very much. It doesn't have the last slide I had, which was a really nice, lovely big picture, which sort of brought all those things together. So just imagine a big picture approach. And so PSF aligns with that 4-stage HQIP model. And so to answer the question, how can clinical audit help PSF? I don't think it's a question of audit helping PSF, but a mutually beneficial relationship to reveal the big picture. and driving effective and sustainable improvement to make your mark in patient safety and prevent avoidable harm. So thank you very much.
Lovely, thank you, Rachel. So I think we'll immediately hand back to you now, if possible, so that you can now talk to us about who's won the Clinical Audit Hero Award for patient safety.
Yeah, the highly commended winner, in a way that sort of aligns with what we've been talking about. The judges were impressed with the shared learning and evidence-informed approach taken, and they're utilising data to build a case for dedicated resource. And that winner is Sandwell and West Birmingham NHS Trust. So well done. Okay, and then now to the winner. So I discussed a bit more about the systems and proportionate aspects of PSERF, but don't want to forget the important element of engaging and involving patients, families and staff. And it seems like this team totally did that in their project. So they demonstrated both innovation and impact far beyond the boundaries of their organisation, with a focus on patient experience alongside effectiveness and safety. And this project was praised for its multidisciplinary approach and patient engagement. So congratulations to Northumbria Parkinson's Disease QUIP team, Northumbria Healthcare NHS Foundation Trust. Big congratulations to you. Yeah, lots of applause.
Oh, lovely. Thank you, Rachel. So I think at this point then we hand over to our fantastic team from Northumbria who are going to present their winning entry. So we'll hand over to yourself, James, now, if that's okay.
Thanks, Victoria. Can you hear me?
We can.
Fabulous. I can't click the take control button. It's grayed out on my screen in terms of the slides.
Not sure why that would be, but I can move them on for you, James.
Okay,
Thanks,
fabulous. Well, I guess the first place to start is a massive thank you on behalf of the team. We're really proud to receive this recognition of the hard work we've been doing, and I did have a look back at previous winners, and yeah, so if I say we're kind of chuffed to be in that kind of same category. So thank you. My name is James. I'm a consultant geriatrician, and I'm just one person of a team of 11. And if you cycle on to the next slide, quite a lot of the team are here today, but this is our team. As you'll see, we're a really broad range of disciplines. They've been the most email responsive team I've worked with until it came to the point of asking them for a picture, at which point everybody went really quiet. So I had to do a bit of trawling for pictures there, so sorry. But basically, I wanted to say how grateful I am to all of you for your hard work and your expertise, because to be honest, without you guys, we wouldn't really have had a project. So yeah, thank you all. It's been a pleasure. So next slide, please. So to orientate you to the structure of my talk, we're going to start off a bit about why Parkinson's. We're going to look at what we did, what we achieved, and then what next. So why Parkinson's? Well, dead easy one, really. It's the second most common neurodegenerative condition in the UK. Every single hour, someone is diagnosed with Parkinson's, and the biggest risk factor for getting it is getting older. So suffice to say, it's a condition that's on the rise. It's also well recognised that control of symptoms of Parkinson's gets worse when people come into hospital. Next slide, please. In 2021, NCPOD did a report looking into swallowing when patients with Parkinson's were admitted to hospital. And I was part of the team that analysed the cases and helped pull the report together. Suffice to say, it showed a lot of variation in practice. There were widespread deficiencies in care for these patients. There was a failure to identify swallowing problems, to act on them and to manage them. The net result of which for many people was failure to administer their medicines. In Parkinson's, that's a big deal. It has a direct impact on the person, but it also can impact on length of stay, morbidity, and even mortality. So this is a huge opportunity to prevent avoidable harm. Now, at this point, I could give you some numerical data to show you the scale of the problem, but we're not going to do that. Instead, I'm going to show you some video that kind of boils it down to what it feels like for the patient. So next slide, please. And if you could click on the video to play it. So this is a gentleman with Parkinson's who's in his back garden walking. The video isn't playing slowly. That is his actual walking, and this is because he's 30 minutes late with his medicines. So you can see he's got a very shuffling gait. He's barely swinging his arms. He's extremely stooped. Watch what happens when he tries to turn. His legs become really sticky and frozen. And you don't need to. It's very easy to imagine him in a hospital setting, unwell, being a massive falls risk. So next slide and next video, please. So this is the same guy in this next video, having got back into the house, taking his medications, and that's him 30 minutes later. So the difference is pretty staggering, really, isn't it? And I think far better than numbers, that illustrates the core message of our project, really, which was to encourage ward staff to remember of the need to get medicines on time. And Parkinson's UK, the leading UK charity, their kind of catchphrase almost is "get it on time." Next slide, please. So the aims of our project, back one, thanks. The aims of our project, therefore, were, as you see them, we wanted to kind of minimize these delays. We didn't want people to be waiting more than 60 minutes for their Parkinson's medicines. And we wanted patients to get their medicines within half an hour in 95% of cases. So they were adopted as our trust, safety and quality targets for year 22-23 and 23-24. Project started off in sort of late autumn 22 when we held initial stakeholder meetings and sort of assembled our dream team that you saw on slide 2. We also did some questionnaires of ward staff, trying to scope out what they knew, what they didn't know, what the challenges they faced were. And really the central component of our intervention has been teaching on the wards, what we term micro teaching. And we've delivered that across 3 intervention wards. I'll go through that in a bit more detail in a minute, but on the next slide, you'll see really what the 4 key messages of this teaching were. So if you could just click 4 times for me. The 4 key messages were: get it on time, think swallow, zero tolerance for missed meds for the reason you see there, and also contact the Parkinson's team. Let us know the patients in hospital. The reason for zero tolerance for missed meds is that, as well as the impact on the patient you saw there, if a patient with Parkinson's misses their medicines for prolonged periods, it can actually become life-threatening. Next slide, please. So one of the first things we did with our project was redesign our trust guidelines to try and make them less text-heavy and a bit more practicable. Here you see a screen grab of pretty much the opening page of the guideline, where I tried to distill in an image, or a table rather, what the first 24 to 48 hours should look like for someone in hospital with Parkinson's. And you can see there's some of those 4 messages I've shown you on the previous slide. Make it in there: get it on time, think swallow, sort of being proactive. Next slide, please. So the way we delivered the teaching, we tried to take the approach of delivering it to folks in their workplace. We thought it's unrealistic to take people out of the work environment for prolonged periods, so we instead descend on the wards. Our practice development team were the leads on this, and we capture people opportunistically, but also after handovers. In total, we delivered the training to 172 staff across 3 wards, and you'll see on the left there that the sort of variation in disciplines. Historically, I think medical staff certainly have protected lunchtime teaching. Sometimes nursing staff do too, but perhaps to a lesser degree. But you'll see some of the job descriptions in there are folks that may not ordinarily get access to training opportunities. And I think, in a project of swallowing in Parkinson's, people like nutritional assistants, for example, I think are worth their weight in gold in terms of their ability to pick up early swallowing problems. So I'm proud of the diverse range of people we were able to get this training to. We also delivered it in 3 minutes. We said that we're going to take 3 minutes of your time. We called it micro teaching. And in essence, that teaching involved those 4 key messages on the blue slide and the videos you've just seen, and a little cherry on top. But that was in essence it. Next slide, please. To try and sort of reinforce that, we have a screensaver that circles on our trust devices just to try and subliminally embed those messages. So that's been working in the background too. Next slide, please. We're also working with our IT teams, redesigned some of the electronic nursing assessments. So you see here a screen grab from the initial assessment a nurse would do when a patient arrived on the ward. And you'll see here the option to indicate the person had Parkinson's. When that's done, if you click for me, please, you'll see that it comes up with a clear visual prompt saying, do a swallow assessment. You'll notice a little line through the nurse bit. That isn't how it appears. That's just to allow me to make the point that more recently we've asked them to remove the would nurse. The reason for that is I don't remember ever getting any training on swallowing assessment at medical school. It's one of those jobs that I think sort of is surreptitiously badged as a kind of nurse in inverted commas jobs. It's a bit like pressure sores and skin integrity. Again, I don't remember any training on it in medical school. It's a kind of nurse in inverted commas jobs, which for me is fundamentally wrong, given the amount of misery and suffering that skin integrity causes, and similarly swallowing problems. So we have been trying to sort of reconceptualize swallowing assessments as not just a nurse job in inverted commas, and removing that word is a small part of that, but encouraging ward teams to encourage their junior doctor staff to get to training is a really important part of this. Next slide, please. Another big part of our project was what's called PD MedCalc. PD MedCalc, you see the website at the top there. To avoid the situation where patients go without their Parkinson's medicines completely if their swallowing is not working, this web-based calculator allows you to calculate a non-oral version of the medicines, be it a medicine you can give it down a nasogastric tube, or be it a medicine you can apply to the skin as a patch. We had this tool developed in-house for a number of years, but had to redevelop it, and the governance around medical calculators has shifted quite significantly. They're now considered to be a medical device, which means you have to go through the same hurdles as with MRHA as you would for a physical device. Now, suffice to say, that was a bit of an odyssey, and there were a lot of challenges along the way, but we got there, and the tool launched in March 2024. Next slide, please. So what did we find? Well, here's a graph with percentage of medications on the vertical axis and time on the horizontal axis. You'll see that the first point is January 23, and it takes us right up to May 24, which is the latest tranche of data. This is all gathered from our electronic prescribing system. The darker line you see there indicates the percentage of medicines that were delayed by 30 to 60 minutes. So you'll see on this ward, we were running at about 35% initially, and we got that down to about 15%. The line below that indicates medicines delayed by more than an hour, which we really wanted to squash. And you can see we went from about 15% to about 7 to 8%. For context, we've looked at this data across the whole trust to see whether there's any trends across the whole trust. And actually, it's pretty flat. There's been no real shift trust-wide. So it isn't just a trust-wide fix. It appears to be the interventions on our wards. If you cycle it to the next slide, please. This is our kind of superstar ward. As you can see, the kind of eye-wateringly high rates of delay initially, over 50% delayed by more than 30 minutes, almost 30% delayed by more than an hour. And we've really squashed that down, to about 10% delay of 30 minutes and low single digit figures for nearly an hour. So it's a real big impact on that ward. And next slide, please. And here you see Ward 6, where the data's a bit more static, starting in a much better place, which may reflect the fact that Ward 6 is our specialist older persons ward. So folks with Parkinson's would often get triaged to that ward, which may reflect sort of greater familiarity, but perhaps disappointing. We haven't been able to squash those numbers down like we have on the other ward. So next slide, please. So 2 more slides. This is what next, and then and then the next slide is kind of key messages. So one thing we're already doing that started about 2 weeks ago is trialing a time-critical medicine wristband. Someone recently told me it looks like a nightclub wristband. I think those days are long gone, so I've got no recollection of that. But it's not for nightclubs. It's for time-critical medicines such as Parkinson's medicines. And the idea is it gives you that visual reminder at the bedside, like, oh heck, I really best prioritise their medicines. Next click, please. We're also mindful that a lot of folks, by the time they get to the ward, have been in the hospital building for quite some time because of the stress on the system. So to try and push this training right to the front door, since April, we've actually trained 105 emergency department staff using the similar training. And I'm actually keen to push this even closer to the front door, even out the front door, i.e. to the ambulance queue. I'd like to see this delivered to paramedics, and I'd like them to be empowered to shout up to say, the patient I've got here has got Parkinson's, can someone prescribe their medicines? So that's where we're working towards. Next click, please. Along the way, we've identified some people who've got a real interest in this and enthusiasm to kind of change things for the better on their wards. So just last week, I delivered the first Parkinson's champion training to 6 members of staff who came up with action plans that they're going to roll out in their own setting. Next click, please. As well as that, we're currently working on micro-teaching part 2, which will be delivered in conjunction with our brilliant Parkinson's nurses we've got in Northumbria. The QR code here links to a website about using art to teach about Parkinson's. It's really interesting. It's worth checking out. I'm quite interested about the idea of using humanities. And there's some great stuff on there about an artist who has Parkinson's, who paints some images when his symptoms are well controlled, and paints the same image when his symptoms are poorly controlled. And I think it's a really striking image. And we used it, we tested it out with our Parkinson's champions training, and I think we're going to be using that more broadly. Last slide, please. So kind of key lessons to share. I think that video, I've lost count of the number of people now who've said, wow, that video, like, I'm not going to forget that. You know, it was really impactful. So I think harnessing the power of patient experience seems to kind of win hearts and minds. There's so many people shouting about things we ought to be doing on the ward. There is a risk that a lot of it can just be lost in the noise. So something like that, I think, really makes people's ears sort of prick up. If you could do 2 clicks for me. I suppose the other thing is the nature of this teaching. I think the fact that we brought it to the workplace made a real difference. And I think the abbreviated format of it, I think when you say to people, right, give me 3 minutes of your time, that's all. I think that's more realistic in a busy workplace. So as we put it, micro-teaching, macro impact. And last click. A couple of the things we used involved tech. They've got loads of potential, but I think particularly the calculator, huge potential for headaches too. A major pain along the way with the regulatory hoops to jump through, and I'm kicking myself for not getting expert help sooner. So if you are thinking of using tech to try and unpick the problem you've got, I'd urge you to hunt down expertise from the get-go. It will probably save you time. Last slide. So that's the end of my talk. Just wanted to again say massive thank you for the recognition, and we're all really, really chuffed to be awarded this. So thank you so much. And again, a massive shout out to the team, because there really wouldn't have been a project without you guys. So thank you.
Oh, thank you, James. That was excellent. And yeah, very, very worthy winners. So yeah, brilliant. Marina, looking at time, we've probably got time for a couple of questions, haven't we? So I'm just clicking on people now to see if we've got any raised hands. So I think, is it Alla? Do you want to take yourself off mute and pop your question to James, or have you lowered your hand?
Oh, sorry, it's by mistake.
Don't worry, not a problem. We did have a question that was higher up in the chat. I think, actually, Rachel, it was yourself that posted it, but you might have answered it with your charts, James. We're just wondering whether there was any difference with patients that had Parkinson's on outlier wards compared to those where people were used to caring for patients with Parkinson's.
I think you did cover it, yeah. But I've got another one, which is, do you see any chance of scaling this to other maybe time-critical medications?
Yeah, thanks, Rachel. Yeah, so interestingly, one of the, in short, the answer is yes. The Royal College of Emergency Medicine are doing an audit currently on time-critical medicines. And interestingly, their kind of figurehead for that is a chap who is an emergency department consultant, but he also has Parkinson's. And if you clicked on that QR code, there's a brilliant video that he developed that tells the story of Parkinson's from the view of his 9-year-old daughter. It's absolutely brilliant. It's a bit of a tearjerker. It's about 4 minutes. I use it in the teaching for our medical students. I'd really recommend checking it out. But in essence, he's the figurehead of a campaign in the emergency department to tackle time-critical medicines, of which Parkinson's are one. So we do have some links about the ED colleagues. We've delivered the training in there, and I'm going to do some sort of slightly longer form training for some of the staff as well.
Lovely, thanks, James. I was literally just writing in the chat for those of you that can stay. We'd really value your feedback, really, in the Menti, which I think Marina's going to share a QR code for, and a link as well. And I think whilst Marina's just asking you for a little bit of feedback, really, I was just going to set you some challenges to take back to your own organisation, and just to thank everybody that's spoken today on the call, really. So thanks to Chris, obviously, bringing in the HQIP perspective for Clinical Audit Awareness Week. Rachel, who's obviously been our key speaker and given us provoked our thoughts, really, on how we can really effectively utilise clinical audit. And what I loved was about the fact that you touched on a number of key things that are now coming later on in the week in terms of the patient and public engagement, the health inequalities, influencing change, and then sustaining change. So it was all linked up really nicely to patient safety, and obviously we'll continue with those themes through week. And thank you to James and your team, really, for sharing your winning project, and also your key learning points from it as well. And I suppose we just want to challenge you all to be a bit bold, ambitious, and identify where you feel that you can actually consider those improvements and actually then make them happen. Thinking about that MDT approach to clinical audit as well, which you saw from James's team as well, that they'd really pulled in every discipline that had a role to play in really making improvements to keep our patients safe, really, and also to enable those improved health outcomes. And then I suppose from a patient safety perspective as well, thinking about other national initiatives that are coming in and how we can then incorporate those into our measurements with our clinical audits, just thinking about some of the latest drivers around deteriorating patients and the new Martha's rule that's coming in. What other initiatives have we also got that we need to consider? And then it's that whole collaborative approach, isn't it, with your patient experience and your safety teams alongside your effectiveness, to really get under to find out what the root cause of the issues are, and then to make sure that our improvement plans, our collaborative improvement plans, can then really help to improve things and make that difference for our patients that are accessing our health and care services. So bold and ambitious, that's what we want you to be this year as you take these challenges back to your own organisation. So I can see you sharing the Menti now, Marina, and people are starting to fill it in. Because as we start to move through the questions, we will be able to see what some of your responses are that are coming through. We've obviously had issues with our link to the lunch and learn today via the HQIP website, but please do join us for the rest of the week, and we'll test those links before we head into tomorrow's lunch and learn. Tomorrow we've got patient and public involvement. We've got Kim Rezel, our head of patient and public engagement at HQIP's our key speaker, and we'll also hear who our clinical audit hero winner is for the PPI category as well. So we're looking forward to seeing as many of you as possible join us tomorrow.
Just answer a question in the chat. The slides I'm recording from today will be made available on our new NQICAN forum on Future NHS. We will make sure that those are shared as soon as possible. So you should have, if you go to menti.com and you're using the code 8296521, you should be able to have this screen that's up, and it asks you to rate on a scale of from 1 to 5 in terms of the quality of both the key speaker presentation, which we heard from Rachel Paul, and also the award winner presentation as well from James Fisher. Just give you a minute for that one. Oops, a few people are still answering, and then I shall move it on. Conscious of time. Thank you very much, everybody, for staying with us a few extra minutes. A slight technical hitch when we started. Okay, I should move it on to the next question.
Lovely.
So in terms of your top takeaways from today's session, so this should be a free text question, if you could all just pop it in. And in terms of what your top takeaways are from the session today.
Yeah, totally agree. Clinical audit can be so powerful and so impactful, can't it? Brilliant.
They're loving your micro
Micro-teaching.
learning, yeah.
Yeah. The fact that you took it out to them, James, as well. Yeah,
Some
that whole
fabulous responses coming
collaboration.
in.
Yeah. Brilliant.
Because all your comments from the evaluations we will be using, you know, and looking at, of course, after the event and taking forward.
Very
Then
well.
just very last questions in terms of if you have any feedback about today's session. Oh,
Yep.
my Menti seems to have jumped off then. Here we go. Any additional feedback about today's session?
Anything else that you would have liked to know as well, because obviously we'll be working with HCRIP to look at what we could do for some follow-up sessions as well through year. As we say every year, Clinical Audit Awareness Week isn't 1 week in time, it's what we do every day. It's just this week gives us that chance to really showcase it and come together with a little bit of protected time to have that focus.
Okay, doesn't
Lacey's Lacey from our comms team at HCRIP's also posted the link to the HCRIP website with all the resources on there as well. So hopefully you've got a bit of time in your organisations with your local plans. So please do access those resources if you haven't done so already. Lovely. And then I think the Menti will stay open for a little bit, won't it, Marina? And obviously the chat's still there.
Yeah.
If you think of anything afterwards, but otherwise we're really looking forward to seeing as many of you as we can on the events that are being run this week and tomorrow's focus on patient and public involvement in clinical audits. Thank you so much for attending. Thank you for bearing with us with our technical issues at the start. Thank you, James, and your fantastic team. And yeah, we'll look forward to networking with you across the rest of this week. So thank you. We'll see you tomorrow.
Thanks, everyone. Goodbye.
Take care, everyone. Bye.